Welcome to the ICD-10 Diagnosis Coding Conference Call. My name is Adrienne, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we'll conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star, then 1 on your touch-tone phone. Please note this conference is being recorded. I'll now turn the call over to Lori Hintz. Lori Hintz, you may begin.
Good afternoon. I am the Nursing Home Quality Improvement Advisor for Great Plains Quinn of South Dakota. Today's webinar is brought to you by the Great Plains Quality Innovation Network, which is a Quinn QIO serving Kansas, Nebraska, North Dakota, and South Dakota. In partnership with our colleague QIO serving Alaska, Colorado, Hawaii, Illinois, Iowa, Minnesota, Michigan, Montana, Nevada, New Mexico, Oregon, Utah, Wisconsin, and Wyoming. Before we begin, there are a few housekeeping items to review. If you have not received access to the presentation handout through your Quinn QIO, you can access them via the link we placed in the chat box. Today's webinar is being recorded and will typically be posted within 10 business days on our website or on your Quinn QIO's website. All lines will be muted throughout the presentation, and if time permits, we will open lines after Maureen's presentation. The chat box is located on the bottom right side of the screen. Please feel free to post questions, and they will be addressed at the end of today's presentation as time permits. Thank you to my colleagues, Holly Beving of South Dakota and Crystal Hayes of Nebraska, who will be helping to monitor the chat function for this event. Today's webinar has been approved for 1.5 education hours for nursing home administrators through the South Dakota Nursing Home Administrators Board. Upon completion of the event evaluation, the attendance certificate will automatically come up, and within that certificate, the verbiage will contain the Nursing Home Administrator CEU information. You can then save it and or print the certificate from your computer from there. With the implementation of the PDPM, patient-driven payment model, slated for October 1st, 2019, diagnosis coding will become even more important. Skilled nursing facility and hospital diagnosis will be reported on the MDS and have major impact on reimbursement. Reinforcing coding skills now will prepare facilities for clinical case mix groupings assigned under PDPM. With that, I'd like to introduce our speaker, Maureen McCarthy. Maureen is the president of Celtic Consulting and is the chief executive officer and founder of Care Transitions. Recognized as an industry leader in clinical reimbursement for long-term care, she has been a registered nurse for over 30 years with experience as an MDS coordinator, director of nursing, rehab director, and a Medicare biller. Adding to her numerous recognitions and leadership roles, Maureen was recently presented the American Healthcare Association 2018 Education Award and has been selected to join on their PDPM Academy training team. Maureen is certified in the resident assessment process, QAPI, and Director of Nursing Services by nationally recognized organizations and holds master teacher status in all 3 certifications. Thank you, Maureen McCarthy, for sharing your knowledge and expertise with us today. I turn the presentation over to you.
Thank you, Lori. Thank you very much. Okay, folks, so everyone who's already received the handouts is probably well aware that we've got a boatload of slides to go through today, so let's get right into it. So we're looking at diagnosis coding for PDPM, or for the patient-driven payment model, and as we're looking at that information, we're going to be talking today about how diagnosis coding affects PDPM in a broader spectrum, but also doing a diagnosis code review so that you can sort of get a little bit more familiar with the different components. I'm not going to go into my bio because Lori already talked about that, and you already have it on the slides if you need it. So we're going to review basic diagnosis coding concepts this afternoon, talk about the 2019 changes to the coding system, because that will influence how we code in PDPM, explain the importance of accurate diagnosis coding, and especially how it affects us under PDPM. So we'll talk a little bit about triple check meetings and, the differences in coding in the medical record versus the MDS versus the claim. we'll talk about a couple of examples on some of the slides of actual coding concepts. And then we'll open it for discussion regarding any coding challenges or questions you may have about diagnosis coding or PDPM, or pretty much for me, anything that involves the Medicare system I'd be able to talk about with you. Okay, so ICD-10 replaced ICD-9 back in October 1st of 2015. The rest of the world had been on ICD-10 for quite some time. They're actually looking at going to ICD-11, and we're just really getting our feet wet with ICD-10 in the United States. So when we move from 9 to 10, 10 gives us a lot more specificity in the codes, and what I mean about that is we can get more specific about the disease that this person has. We can get looking at, different ways to code things and the ways it manifests in certain people's bodies versus another person. You can really get specific about certain diseases, and you'll see some of that with the slides that we go over today. We're going to talk about the structure of the ICD-10 system and how it's set up, where the decimal points are, what all the letters and numbers mean, and those types of things. So the structure of ICD-10 gave us the ability to add more specific codes. So, for instance, Zika virus that we've been hearing about the past couple of years, we never heard about that 20 years ago. So there wasn't a diagnosis code for it 20 years ago, but we needed room in the infections to address the Zika virus. So similar to other disease and progression of diseases, sometimes you need more, more room to get more specific about a disease. And ICD-10 does give us that with these 7 characters in a diagnosis code versus the 5 that we used to have under ICD-9. So there's more room there to add more codes as we find more diseases in our lifetime. We're going to talk about coding conventions. And general coding guidelines. So there'll be some general guidelines as far as coding goes. There'll be chapter-specific guidelines, and those are specific to certain diseases, okay? And they're split up by different chapters, which I'll show you on the subsequent slides. And then we're talking about different coding conventions, which are specific rules around ICD-10 coding guidelines that we have to follow as well. Okay, so ICD-10, we have some updates in 2019 for ICD-10. About 279 codes were added. We had about 51 deactivated and about 143 codes that were revised that had already been in the system. And every year we go through this. I have to say the majority of the codes that were, added or rearranged really aren't usually in long-term care. They're usually codes that are specific to a physician's office and external cause codes, which we'll talk about later on, with how did the patient get the injury. And long-term care, it's not really relevant how they got the injury. It's more relevant what the injury is. So we're going to review some of the changes from 2016 through 2019. Again, 2015 was the first year we got ICD-10, and then so 2016 was the first year they changed ICD-10. So we'll review some of those changes as we move along since the transition from 9 to 10. So again, why do we have to do ICD-10 coding? Well, number one, we have to because the rest of the world has been waiting for us to catch up. But the second thing is that ICD-10 coding is used for a lot of different purposes, okay? So we're able to collect diagnostic information and statistical information about people with certain conditions and are treated by certain healthcare providers. So we can look up based on the historical data how much rehab or how many days in a nursing home does the average hip fracture take? What about a hip fracture with COPD and CHF? How many nursing home days do they use? How much rehab do they use? How much aftercare do they need once they get out of the nursing home? So all this data has been collected based on the diagnosis code. And as we submit claims and MDSs, whether the claims are inpatient or outpatient, CMS can gather that information to determine how diseases function differently in either different parts of the country with different comorbidities, and again, a lot of opportunities for research. It's going to help us to make some clinical decision-making. Again, should we add something to the care plan based on certain diagnoses that the patient has or combinations of certain conditions might put them at a higher risk? And again, the clinical decision-making would be affected by that. Obviously, it supports reimbursement for the services that we provided. So when we're talking about claims, the diagnoses that should be on the claim are all those that are relevant to why this person is in the nursing home. So if they came in with a fractured hip, but they also had Parkinson's, that's going to help me understand why this person may need a longer length of stay, because maybe they can't tolerate as much therapy as a person that doesn't have any comorbidities does. It explains to me as an auditor why someone would be on a longer length of stay, because the Parkinson's will slow down that person's recovery from that hip fracture. Okay, so it helps with the understanding the reimbursement component. The other thing is that you put the ancillary charges on the claim anyway, so the diagnoses code that you have on the claim should really represent the conditions that you're treating, as well as what you're billing for, your ancillary services. It should make sense and tell a story. Again, to comply with federal standards for reporting diagnostic data, so what that means is we have to do it. And then to provide clinical research for CMS as well as others that may have access, and how to improve quality. Looking at quality improvement activities and opportunities based on what we learn from the diagnosis coding at certain levels of care. So in fiscal year 2017, there were a lot of changes to the ICD-10 system. Again, looking at code assignment and clinical criteria of when you code something. I wanted to go over this slide because as we move into PDPM, you might ask yourself, what supportive documentation do I need from the physician other than a diagnosis to prove that this person has this condition, had this condition, or is developing this condition? Excuse me. So this slide tells us that the assignment of the diagnosis code is based on the provider's diagnostic statement that the condition exists. So if the doctor says that they have the condition, then they have the condition. You go ahead and convert that condition into a diagnosis code, and then you put it in the appropriate spot, okay? So it's not based on any additional criteria other than that physician documenting that the person has the condition. So coding acute codes in a skilled nursing facility setting. Sometimes we do have folks that come in that are having an acute bout of a certain condition. So it might be something that they treated in the hospital that continues to require follow-up on our part, or an acute diagnosis that has, they're having an acute episode of a diagnosis. And again, some examples that we give are when someone is discharged from the hospital, they have a diagnosis of pneumonia, they come to you in the skilled nursing facility setting, they're continuing with nebulizer treatments and antibiotics and observation and assessment. Those skilled needs would be something that would be covering the patient on Medicare Part A for, and therefore it would still be an active diagnosis. The status of the acute condition could be assessed when the patient gets to us. Every week at our Medicare meeting, or whether you have other meetings in between, a 24-hour team-based meeting, a 72-hour team-based meeting, a discharge planning meeting, a PPS meeting, whenever, okay? So you can monitor whether they're still in that acute status or not, and then update that condition. If someone has conditions that were treated that are now resolved or have been resolved in the hospital, those are not reported in long-term care. Sometimes they may be in a physician's office, a history of, a family history, things like that. Those generally aren't really required in long-term care. They're just active codes that we're looking for. And then again, the Z codes, as there's been a lot of drama when they were called Z codes before, but those Z codes are capture the aftercare, and we'll talk specifically about those when we get to those chapters. So let's talk about the difference between something that's a billable code versus a medical records code. So sometimes for those of you on the line that are clinicians, you may have your biller that comes back to you who says, this is not a valid code. Now, you're speaking a little bit of two different languages here when that happens. What the biller is telling you is that the code that you gave her doesn't pass over your Medicare administrative contractor or your MAC. Meaning the MAC doesn't like this code in long-term care. So an example for those of you that are clinicians that have done coding would be someone that has a 7th character A code at the end. That's generally the initial encounter. Usually that's reserved for the hospital setting, an emergency room, or a doctor who's coming in to evaluate that condition, who's then going to tell you as the provider what to do about that. So when we get orders for PT, OT, speech, or, something else for a person that has a condition, when the doc tells us what to do about that and sets that plan of care, that's the initial encounter. We're the subsequent encounter. So sometimes A code, 7th character A codes will get submitted and then will get rejected by the MAC because what they're saying is this isn't generally provided in a skilled nursing facility. Now, never say never, but at least at this point in time, we generally see 7th character D or 7th character S or something else if it's related to a fracture. So the biller's telling you that this may be an acceptable code because it's a valid code that you can find in the ICD-10 diagnosis coding book, but it's not accepted by the MAC for our setting in skilled nursing facility. So you need to keep those two things sort of separate in your mind. So when you're looking at diagnosis codes, especially when you're looking at something that's going to go on the claim, you need to ask yourself, is it reasonable and necessary to bill Medicare Part A for the condition that's being reported with this diagnosis code? Or is there a better code that we should have used to explain the condition? Then we need to look and make sure that we all have the same information, whether it's MDS, rehab, a clinical person, the physician, the APRN, the nurse practitioner, those PAs. We have to ask ourselves, who has the most specific code here? Sometimes it's going to be, somebody from the MDS department. Sometimes it's going to be CHAP. Sometimes it will be the provider, the physician, the nurse practitioner, or one of those folks. So again, just because they tell you it's not a valid code doesn't mean that it's not valid in the ICD-10 book. What they're telling you is that this is not a valid code to bill in the skilled nursing facility setting. Okay, so co-layer coding in the MDS, that's a little bit different too. So ICD coding has a lot of guidelines, and the way you code in ICD-10 and the MDS may not be identical, and sometimes they are not. It's going to be necessary for MDS coordinators to have knowledge of appropriate coding guidelines. And again, the REI manual is our Bible when it comes to all things MDS. If there isn't anything specific in the ICD-10 manual that addresses sequence of coding, then we go to the REI manual to look for that. So section I is where we keep all the diagnosis information in the MDS, and that contains a lot of specific information. Sometimes we're limited from what we can put in there. It has to be something that's active in the last 7 days, which means that nursing is doing some kind of treatment, some kind of oversight, medication, tests, labs, those types of things. And then when we're talking about PPS and we're looking at correct diagnosis codes to support what's being billed, the way you code in the medical record, okay, you're putting everything in there. The hysterectomy from 1947, I had my tonsils out when I was 2 in 1923 or whatever, all right? All that goes in the medical record. The MDS only has those diagnoses that were in effect in the last 7 days. So they were active in the last 7 days, diagnosed at least in the last 60 days, and there's something that you're doing something about. You have a care plan developed for this, you're monitoring for something, hopefully you're putting something specific about what you're monitoring there, and then there's the claim. The claim should only have those diagnoses that you cherry pick out of your list that have to do with why the patient is skilled. So if someone is on a high cholesterol medication and they're in there for a fractured hip, chances are that high cholesterol has nothing to do with why you're skilling the patient for the fractured hip, should not go on the claim, okay? So your purpose of the diagnosis codes on the claim is not to fill it up with garbage. It's to fill it up with codes that will tell the story about why the patient is skilled. They had this condition, they had this procedure done, we're monitoring for these other things that affect them. Like I said, if someone has a fractured hip and Parkinson's, I'm going to want to see that on the claim. It'll explain to me why they need 60 days of care and why they can't get out in 25 days. Okay. Auditing and QA, we have to monitor the appropriateness of the diagnosis codes that are on your claim. So again, if you do not do diagnosis coding as part of your triple check review, you need to start. And if you don't do triple check review, again, it's a really good practice. You really should consider doing that long before you get into PDPM. So when you're reviewing the claim and you look at the diagnosis code, you have to ask, do diagnosis codes agree across the disciplines? Is what we're reporting on the claim the same thing that we have in MDS, the same thing that the doctor has, and the same thing that we have in rehab? We may all have 3 different codes to explain the same condition. Whose is the most specific, and do we have the backup documentation for that? So all required codes should be reported, And then Billy should also be coming back and letting the interdisciplinary team know if any claims were denied, returned to provider, or suspended so that we can get those corrections made, especially if they have to do with diagnosis codes. So that should be discussed at the weekly Medicare meeting, if not sooner than that. So again, update your triple check process to include a diagnosis review if you haven't already done it. And if you think it was important before, it's going to be even more important under PDPM because it's diagnosis or condition based. Again, reviewing the rejected claims. Were the rejected claims resubmitted? Did we get the correct code to the biller? Was she able to add that to the claim? And we can now turn around and submit that claim. Again, and did we look at all of the disciplines to determine, usually MDS and rehab and the physician are the ones that either looking at diagnosis coding or the most involved with it. So again, we have to make sure that we're providing the right information. Drug regimen review. Let me just talk about this for a couple of minutes here. When it comes to drug regimen review, this is a piece that CMS added October 1st of 2018, so just this past year, okay? It includes a medication reconciliation as part of the drug regimen review, okay, which includes the medication that the resident is currently taking, verified against the medications that the resident was taking at the hospital, and don't forget this part, review against the medications that the person was taking at home. Because attached to a medication is an indication for use. The indication for use is a condition or a diagnosis that the person has. So if they were using a supplement or an herbal or something like that to treat a condition, I have to let you know that when the patient goes to the hospitals do not give them all the medications that they were on at home anymore. They're only giving them what they need to stay alive or what they need for this specific admission. So you could be missing conditions if you're not reconciling with what the person took at home as far as medications go. So add that piece to your drug regimen review now if you haven't done it already, because you could be leaving conditions on the table, and we know that conditions or diagnoses are what give us revenue in the PDPM system. So just a little bit about that, making sure that, you're following that appropriately, because those diagnoses and conditions, are something that could mean a difference of, $30 or $130 a day. Okay, so again, prescribed medications, over-the-counter medications, they're asking about nutritional supplements, vitamins, any homeopathic or herbal products, and again, administered by any route. So they could be topical, they could be gels or ointments or creams or anything that the patient's taking. The other thing to remember is TPN is included, and so is oxygen as a drug, believe it or not. All right, when it comes to therapy diagnosis codes and then looking at primary codes, if the patient's coming back with multiple conditions, we have to look at whether they're still active or not. Okay, so a long-term patient with Parkinson's disease leaves the nursing home, goes to a hospitalization, goes to the hospital for pneumonia, and comes back, and he's eligible for Medicare now. So the therapy plan of care gives us the medical diagnosis on why they're skilling the patient of Parkinson's, because that's the functional problem that the patient had that causes PT and OT to want to come in and work with the patient because they've had a decline. If the pneumonia is then resolved, then the primary diagnosis is going to be Parkinson's, okay, because at this point, rehab is driving the train as far as the skilled service goes. If the pneumonia is still active, then the primary diagnosis is the pneumonia, and the Parkinson's is the secondary diagnosis, because that's what rehab's utilizing to treat the patient. So both conditions should be represented on not only the MDS, but on the claim as well, okay? Most importantly, it should be on the claim, because the pneumonia should be resolved and followed up, in a short period of time. But the Parkinson's diagnosis tells me that this person is going to take longer to recover than someone who just has pneumonia and no other comorbidities. So with ICD-10, it gives us additional opportunities for granularity. And what I mean by that is it gets you into a more granular description of what this person's condition is. So the level of hierarchy and the amount of information increases the further you get out to the 7th character, okay? So it always starts with 3 characters, but you can get out more specific out to 7 characters. So some of the things that we have to know are laterality. And I want to spend a couple minutes on this because this is extremely important in PDPM. If you have 2 of anything in your body, CMS wants to know if you're treating the right one or the left one. When it comes to eyes, ears, arms, legs, lungs, ovaries, things that you can see and things that you can't see, okay? So the right side is usually characterized by a character 1, by the number 1. Left side is usually a 2, and bilateral, meaning it affects both sides, is usually a 3. They also have unspecified codes available, which give us either a 0 or a 9. It's going to depend on what the 5th or 6th character is in that coding family. But the unspecified codes, the majority do not cross over to PDPM. So if someone's coming into you and they have a dislocated knee, you're going to need to know if it's the right knee or the left knee, because an unspecified code doesn't cross over in PDPM, and therefore you can't get a case mix group to bill with, okay? So hear me right when I say that you really need to know if it's the right side or the left side for these conditions when you're reporting, especially for the primary reason for coverage. So under PDPM, again, the importance of accurate coding is even more emphasized because that's where your money comes from. It's not rehab days and minutes anymore. It's basic conditions, which are diagnoses. So reimbursement is going to depend on what diagnosis that you pick, especially with PT and OT components. Again, the non-therapy ancillary components. The 3 areas that are most dependent on diagnoses are going to be looking at PT, OT, and speech. It's going to set up the basis for the reimbursement that you get by what's the primary reason why I'm skilling this person on Medicare Part A. Your nursing RUGs, and I'd say RUGs, even though we're talking about PDPM, is because the nursing component is based on the RUG scores that you have now for the nursing side. So everything from the ES through your trach and vent patient all the way down to PA1, okay? So those folks are still going to be using those RUG scores, so you need to know what is considered skilled. And again, your level CA1 and above, all the way up to ES3 on the nursing side, you're also going to need to know the non-therapy ancillary diagnoses and conditions that can get you more revenue on that side. So, for instance, on the nursing side, if someone goes on to isolation because they have, let's say a respiratory MRSA, and they go on antibiotics and they're on isolation, you're going to get more non-therapy ancillary points for the isolation and for the antibiotics, and then you're going to be in a higher nursing score. So you're going to want to potentially do an IPA or interim payment assessment based on that opportunity, again, looking at where that revenue is going to bring you. Now, your IPA or interim payment assessment is the sort of middle-of-the-road MDS that you would be doing, and when you do it, it's going to depend on your own facility assessment, so you should be looking at getting those together at this point in time. This is where you're going to be filling out the majority of the diagnosis information, again, in Section I. The boxes that you can see in 1 through 13 will not be used in PDPM. They will only be used in quality reporting. Now, currently there is a box number 14 on the MDS. They're taking that away. And you can see down the bottom here your I-20B ICD code that will be used for your primary reason for skilling the patient on PT and OT. And again, it sets up the condition categories for speech as well, all right? But keep in mind that diagnosis code is going to set up that basis in I-20B. So most of our patients come in with multiple comorbidities and multiple conditions. So start trying to pick that code now so you can master that skill long before you get to October 1st. The other thing you're going to be documenting on are surgeries that are applicable to PDPM. So they're going to add this question, J2100. Did the resident have a major surgical procedure during the prior inpatient hospital stay? That's usually the qualifying stay if they're coming to you directly from the hospital. But if they've gone home first or to another setting and they're coming to you, it would be that prior proximal hospitalization, okay? And again, does this condition require active care in a skilled nursing facility? You're going to say no if they didn't have any. You're going to say yes if they did have the surgery, or if you don't know if it's in, if they had it or not, you're going to say unknown or number 8 here, okay? Then if you do answer a yes, you put a number 1 in the J2100 box influencing the yes answer, then it's going to open up the rest of these boxes, okay? So we're looking at surgical procedures here, and this is where you may have heard in the past where CMS said that we were going to have to learn the ICD-10 PCS coding system, which brought hysteria out in our level of care, because that is way too much for anybody to have to take on in addition to PDPM. They don't code in the same type of a system in the hospital that we use. We use the ICD-10 CM version. The hospital uses PCS. That means that your coordinators would have to learn both systems. No. So we asked CMS at the Train the Trainer last year, could you just give us the surgeries that you will include in a drop-down box, and they did that for us. So we should be very thankful to them that that happens, so we don't have to learn a new system. So when we're looking at the types of surgical procedures that they're considering for this, they're looking at, you can see your joint replacements, knee, hip, ankle, and shoulder, and those are total or partial joint replacements. And your spinal surgeries, your other orthopedic surgeries, again, which could be repairing fractures, but it didn't require a joint replacement. Other repair of the joints and things like that, other major orthopedic surgeries would be under here. Your neurological surgeries, the grounding the brain, tissue, blood vessels, those sorts of things, neurotransmitters, and your cardiopulmonary surgeries that involve more blood vessels, lungs, bronchi, stuff that's in your throat, that sort of a thing. Your GU surgeries, male or female organs, kidneys, ureters, or other GU. And then we have the other major surgeries, which could involve tendons or ligaments, so it's not really bones. GI surgery, endocrine glands, breast surgery, especially for those folks that are having mastectomies. Deep repair of pressure ulcers would be in this one. Or if any other surgery that they had was not listed above, you're going to put that in J5000 in the last box. You'll check that last box. Let me just go back to that for a second. These opportunities for the surgeries can sort of upgrade the category for the patient based on the reason you're skilling them. So there are some opportunities to get a better category placement, but it's really going to involve those orthopedic reasons, and some others for the surgeries that they've had. So again, depending on what surgery that you had in the look-back period, you could be getting additional revenue for PT and OT based on the surgery. So if they're coming to you for pneumonia, but they had a hip replacement in the window, then you're going to be looking at upgrading to that joint replacement category, which gives you more dollars for PT and OT. But if you think about how CMS put it together, it makes sense. Just because I'm coming for pneumonia now doesn't mean that I no longer have any needs for the hip replacement that I had 22 days ago, okay? So it's smart that they set it up this way because they can recognize, other than the primary diagnosis, some folks that would need PT and OT as well. Okay, so let's get into the alphabetic index of the manual. So it's divided into 4 parts. We have the diseases of injury, index of diseases and injury. So those are going to be split up by the specific diseases that the person has. Like I said, they're in alphabetical order. So this is the first place you look when you're looking up a diagnosis code, okay? They also have an index of external causes of injury. We're not even going to talk about that because we don't use that in long-term care. And what I say when I'm teaching this class live, usually, is that no one cares how tall the bar stool was that you fell off when you broke your hip. They only want to know, what are you here for? The broken hip, okay? Table of neoplasm, you're going to need that when it comes to those folks that have cancer because we're splitting them up by the type of neoplasm that they have, and you'll need to refer that because when you get into the cancer, you're going to need to know where on the body that they have this cancer, what site is it at. So that's one of the levels of specificity that we need to get to in the ICD-10 system. Tables of drugs and chemicals, we would use that if someone was poisoned, overdosed, underdosed, burnt, has a corrosive or other type of burn. That's where we would be going to look at some of that information. A tabular list, so you're starting in the alphabetic list to get the coding family captured, then you're taking that information back into the tabular list to verify if you have all of the characters that you need for that code to be appropriate. So the tabular list, again, is divided into different chapters based on body systems or conditions that the person has. So, again, we start in the alphabetic list, That lists the main terms in the coding families. So again, you have the table of neoplasms and drugs and chemicals that we look into. The tabular list codes divided by chapter, and each chapter is arranged by body systems, so cardiac and pulmonary and musculoskeletal and things like that. And the tabular list is where you go to find the final code. You start to look up the beginning of the code in the alphabetic, then you take the information you've got into the tabular to see if that's the final code or if you need additional characters or not. You never want to code strictly from the alphabetic index. You're probably missing specific information. And again, as we move into PDPM, they want more and more specificity. I'm going to guess that we're not done with the diagnosis crosswalk list, that will change throughout our lifetime every year. All right, so the format and the structure of the codes under ICD-10, the tabular list contains categories similar to the alphabetic list, but the tabular list also includes subcategories in the actual final code itself. So the characters can be letters or numbers or a mix. It always starts with a letter. So every diagnosis code starts with a letter anywhere from A to Z, okay? The coding family or the coding category is 3 characters that starts with that letter. Then as you get further out past the decimal point, so there's 3 characters and then there's a decimal point, same as it was in ICD-9. Anything after the decimal point is either the subcategory or the final code. And the manual itself will tell you whether you need 4, 5, 6, or 7 characters to make that a valid code. So pay attention to that when you're in the manual. So after you get that family category or condition category or clinical category, then there's the subcategory and then the final code. So this is the way that the chapters are set up. Again, A and B are your infectious diseases. It goes, it's a pretty long list. Your neoplasms start in chapter C, so C for cancer is an easy way to think of it. Although it does float over into D, it goes from C00 to D49 because there's so many cancer codes. But if you think in your mind C for cancer, you're generally on the right theme. Your endocrine, again, your E chapter is where you're going to find a lot of information about your diabetes patients. F, your mental and behavior, neurodevelopmental disorders. Again, we don't use primary codes from the F chapter very much, or the G category as well. There's some nervous system items there which are very relevant to us in speech therapy, but this is also where your dementia, some of your dementias, your Alzheimer's would live in this category as well. H, your eye and ear. Your eye, your circulatory, so there's a lot of changes to circulatory. We're going to spend some time on that chapter. Your respiratory, digestive, skin, this is where your pressure ulcers live in chapter L. M, your musculoskeletal as well as osteoporosis are in this chapter. N, your genitourinary. O is for pregnancy and P is for perinatal. We're not going to talk about those at all because you can just imagine how many of those we get in long-term care. Your Q, congenital, again, usually not a reason for killing a patient. Your R, signs and symptoms. This one we're going to spend a little bit of time with because your therapy folks are using mainly R codes and some of the M codes as diagnosis codes. So I just want to warn you folks that are on the call now, especially those of you that are R coordinators. I know the 4 codes that you get from your rehab folks. You have weakness, then you have generalized weakness, you've got unsteady gait, and you've got gait disturbance. I can tell you right now that none of those 4 codes cross over to PDPM. Okay, so you've got to get your therapist to start documenting more specific codes and less general codes. Okay, that's what I wanted to talk about with that. Your S and T are your injuries. You're going to find your fractures in there, your dislocations, as well as some poisonings in chapter T. U is reserved for emergent codes. We don't build that in our setting. V, W, X, and Y, again, all external causes. Like I said, no one cares how tall the bar stool was that you fell off of. We just want to know why you're here, which is the hip fracture. And then we'll spend some time with the Z codes, which used to be called Z codes in the past. All right, so we're starting off with a 3-character category. So like I said, they all begin with a letter, okay? Each chapter begins with a list of blocks or subchapters that are in these categories. So, for example, chapter 2 is looking at the neoplasms. Starts with codes beginning with C00, goes all the way up to D49, okay? So the way it's split up, and you can see in this example, C00 through C75 are all malignant neoplasms, okay? So you can have some benign, all right? So what you're looking at now are just C00 through C75 are malignant neoplasms. Now, further divided, C00 through C14 are malignant neoplasms of the lip, the oral cavity, or the pharynx. Moving on to C15 through C26, you've got malignant neoplasms of the digestive organ. And then it would go on to other body systems until we got all the way through D49. Okay? But again, these three characters are only the beginning. You need to take this back into the neoplasm table, then you need to take that back into the tabular list to make sure that you're not missing anything. Now, fourth character categories or subcategories, you can see this little red circle here that says check the fourth, meaning check for a fourth character. So the manual will always guide you as to how many characters you need to have a valid code. Pay attention to that. So your fourth character either further defines the site where this problem is, the etiology, how did they get it, or the manifestation, how is it showing itself in this patient versus another patient. So you can have someone that has diabetes that manifests itself with peripheral vascular disease, or you can have someone that manifests itself with diabetic retinopathy in their eyes and they can't see well. Okay? So depending on how that affects the person, that will be included in some of that code. So we give you an example here. It includes the 3-character category, a decimal point, and then the option for additional characters. Okay, so we give you purpura with other hemorrhagic conditions. So D69 is purpura, so you have two options. Is it D69.0? Was it related to an allergic reaction? Or was it D69.1 and it was related to qualitative platelet defects? Okay, so it's going to depend on why you have the purpura, which is little purple dots all over your body. Did you have an allergic reaction to something, or is it related to your platelets? Those are the two choices that you've got, either a 0 or a 1. When it comes to 5th and 6th character subcategories, again, let the manual guide you as to whether you need 5 or 6 of those, okay? We give you an example. We're right in the middle of flu season, actually probably wrapping it up now. You have J10.8, which is saying that this person has influenza due to other identified virus with other manifestations. So the manifestations that we got to choose from are 81 or 82. You can see below that J10.81 or J10.82. So that both patients still have influenza, okay? The 81 had influenza so bad that they ended up getting encephalopathy, so their brain ended up swelling. The second patient had influenza so bad, the 82, that they ended up getting myocarditis, so it ended up going to their heart. It manifested in 2 different ways in 2 different patients. And that's what the 5th and 6th characters are there to explain, to say, yes, she had the flu. We identified that it's a different influenza virus, and this person ended up getting either encephalopathy or myocarditis as a result. 7th character extensions, again, in the dummy placeholders. Some categories require a 7th character, and again, manual will guide you for that. If you do not have the opportunity to add a 6th character, you cannot put the 7th character in the 6th character spot. So what you have to do is put an X where the 6th character should go to hold the place open. Because if you move the 7th character up into the 6th character spot, it means something different. So you can't do that. So you're going to put what we call a dummy placeholder in any spot until you get to the spot where you need to be. And in this example, we're talking about the 7th character. All of our fracture codes require 7th character. Most of our injury codes require a 7th character. And again, the tabular list will help to guide you, make sure you're getting out there. So this is an example of someone that has an unspecified fracture of the neck of the femur. I can tell you right now that S72.00 is not going to transfer over to PDPM. Okay, so we need to know more information. You need to know if it's the right femur or the left femur. Okay, which thankfully with a fracture is easy to tell because all we have to do is really whip down the covers and find out where the suture line is on the right side or the left side. But some conditions like a pneumonia where the lungs are inside the body, you're going to need to query the physician or the provider to find out more information. So the next example, S72.051, gives us an unspecified fracture of the head of the right femur. So we have the S72 telling us that it's still an unspecified fracture, okay? We're still looking at 0.0, it's going to be of the femur. The 0.5 tells us it's the head of the femur, and the 1 tells us it's the right side. Okay? The next code down, S72.111, tells us the S72 we're still with a fracture. The 0.1 tells us it's not unspecified anymore, it's displaced. We know what type of fracture. It's a displaced fracture. Where is it? It's on the greater trochanter, which is the second one, and then it's the right side, and that's the third one. So you can see S72.111. The first one tells us it's displaced. The second number 1 tells us it's greater trochanter. The third one tells us it's the right femur. That same injury on the left side, okay, in the next example, S72.112 tells us it's the left femur. Or the S72.109, unspecified fracture of unspecified femur. Again, not going to fly in PDPM. Okay. All right, so the 7th character, we give you an example here of someone that had a subluxation and a dislocation of the patella, which is the kneecap. So S83.0 gives us subluxation and dislocation of the patella. The S83.00 is an unspecified subluxation and dislocation of the patella. Okay, so again, still not specified enough. So then we go down a little bit further, and let's say we go down to the patient's room. We pull down the covers, we see that flaming hot knee, and we know that it's the right side. Okay, so we have more specific information now. So now we look at S83.001, which tells us it's the right patella, but it's leaving that spot there open, you can see that line, for the 7th character. So it's not a full code until we put the 7th character in. So in this example, we only have 3 choices to choose from. Either it's A, initial encounter, which is not us, D, subsequent encounter, which can be us, or S, sequela. The sequela is generally saved for a condition that you've already treated that's sort of coming back to haunt the patient now, and it can be, days or weeks later, or it can be years later. Sometimes we have someone that had an old football injury from the 30s when they were in college that's still bothering them, and that might be a sequela. We see a lot of sequelas when it comes to Medicare Part B treatment, especially with our rehab folks. All right, so here's an example of code structure. We have someone that we're representing a code that this person has chronic gout, okay? So the M1A tells us that the coding family or coding category represents chronic gout. You have your decimal point after the 3rd character like all of them do. Then the 4th character is going to address etiology, okay? So it's going to tell us how did they get this gout related to renal impairment. Okay, so then we move to the 5th character. The 5th character is a 1, which is going to denote where it is in the body. So we know that it's the shoulder. So M1A.3, renal impairment, 1, the shoulder. And then we need to know you have 2 shoulders. Is it the right or the left? So in this case, it's the left shoulder, which gives us the M1A.312. Now, gout also requires us for an extension. It wants to know if we have with or without tophet. And in this example, it's without tophet. So we have a full 7-character category for gout. We have the etiology, we have the location, we have the laterality, and we have the extension. So again, the dummy placeholder, this is an example of someone that had a ruptured lumbar disc, okay, and it's a subsequent encounter. We do not have 5th or 6th characters, so we put the X's in there as dummy placeholders, and the D goes at the end in the 7th character spot. You can't move it back up to the 6th or the 5th. It's got to stay in that spot. Again, when it comes to fractures, I'm going to give you a cheat sheet when we get to that chapter, but just so you understand, there's things that you're going to need to know about your fractures before you're able to code them. Like the 7th character fracture includes more specificity than just laterality alone. It wants to know about different types of fractures. Is that fracture opened or closed? Okay? It's usually when it's fresh, it's easy to tell because if there's a bone sticking out of the skin, oh, it's open. Okay? But after they've done surgery on that, it's a little bit more difficult to tell. And usually it's such a hot topic or event that it will likely be in your OR report and in your ER report and probably in your discharge summary as well. Other items that you might need to know are whether it's delayed healing or routine healing, and whether it's malunion or non-union. Okay, so those are some things that we would need to know about that fracture. And again, we don't get a lot of this information from the doctors. So we're doing the best we can with the documentation that we've got at hand. Sometimes we may need to call to get more specific information, and sometimes we just have to go with what we've got in the medical record and sort of make the best of it. So like I said, I'll give you a cheat sheet on that. A couple of rules when it comes to traumatic fractures. Now, traumatic fractures are those that you got as a result of an injury, okay? Sometimes you have folks with osteoporosis and the fractures just develop, they just happen. There wasn't an injury that happened, a fall or anything like that. These traumatic ones, we're looking at something different. There was an injury or an event. So if documentation in your medical record doesn't indicate whether that fracture is displaced or non-displaced, you're going to code it as displaced. If it doesn't correlate to whether it's an open or a closed fracture, you're always going to code it as closed if you don't know. If the seventh character is usually going to be a D for subsequent care or subsequent encounter in a SNF, or if we have some other complication, malunion, non-union, or whatever, we would use those appropriate codes. And like I said, when we get to that chapter, I'll give you your cheat sheet. So aftercare codes like D codes are not used when the person has a fracture, even if the hip was replaced. You're going to use the seventh character D to tell CMS that this is aftercare after the fractured hip. Okay. So again, the other thing that you need to keep in mind is if you have folks with multiple fractures, you're going to code in the order of the most severe. So if you have an open fracture of the femur and two closed fractures of the radius and ulna, which are in your lower arm, the most severe is going to be that open fracture of the hip. So that would be sequenced first, and you would have the radius and the ulna as secondary codes. Okay, so whatever's the most severe. Again, the last space is usually a D for that seventh character. An A is usually in the acute care setting or the physician's office, and the S is for late effects or residual effects or sequela of that condition. Okay. If the code only has 5 characters but requires 7, you're going to need to put that dummy placeholder in there. Okay, so these are just some general rules about fractures. Sometimes we're not going to have enough specific information about a code, and we are going to need to query the physician, okay, which means you need to dig deeper for a more accurate code or more specific information so you can get to that more accurate code. So sometimes you may need to call the physician who's covering in the nursing home. Sometimes you may need to call the hospital. Sometimes you may need to call the attending in the community, depending on where the diagnosis came from, okay? You may need to talk to the physician or the nurse practitioner or the physician's assistant or the clinical nurse specialist, all right? Any of those folks are allowed to diagnose patients. You want to stay away from unspecified codes when you possibly can because, again, a lot of those do not convert over to PDPM. Laterality, you're going to need to know. And if you don't know, you may need to call and ask. And a lot of ICD-10 has combination codes that are bundled together, specifically when it comes to diabetes and some other conditions that are related to diabetes and heart disease, when some conditions as a result of having heart disease, and when we get to those chapters, we'll talk about those. But don't unbundle them if they're bundled together because you're killing 2 birds with 1 code there. Okay, some of the coding conventions, all right? These are general rules about coding that come from the people that make the ICD-10 codes. They're used in both the alphabetic list as well as the tabular list, the coding conventions are. So NEC are not elsewhere classifiable versus NOS not otherwise specified. NEC or not elsewhere classified means that they didn't invent a code for that condition yet, okay? Or it might not be classified any more specifically than what you're finding in the manual. So they don't have a more specific code for that. This is the best that the manual can do. NOS, not otherwise specified, means that you don't have enough information in your medical record to get a more specific code. So one of them is that there isn't a code available, and the second one is makes us look bad. It makes us look like we don't have enough information to assign an ICD-10 diagnosis code, okay? Some categories may not have an unspecified code, so it'll say other specified. It'll send you to another place in the manual to look, okay? So other and unspecified means it's going to send you someplace else. Okay, so other specified means that this other code is going to give you more specific information about the condition that you're looking up. Okay, information is available in the medical record, but a specific code doesn't exist, so we're going to send you over to this other code that is specified that's similar to what you're looking for. An unspecified code is usually on the information you have, you can't get a more specific code, or when a more specific code doesn't exist in the manual either. Sometimes they'll have an unspecified code. Not otherwise specified means you don't have the information either. So both of them can mean that thing, but sometimes an unspecified code just isn't available, and not otherwise specified means that we have one available, but you need more information to determine which one that it is. Okay, includes notes and excludes notes. We're going to spend a couple of minutes on this because this is going to make a difference as to how you choose the code. So includes notes are found in the tabular list immediately under that 3-character code or character family or condition code. I've been calling it many different names. So the example that we give here is G30 Alzheimer's disease. It includes 2 types of Alzheimer's disease, senile and pre-senile forms. So it's telling you that regardless of what type of Alzheimer's, if it's senile dementia, Alzheimer's senile, or Alzheimer's pre-senile, both will be included in the G30 coding family for Alzheimer's disease. Okay. So there are inclusion terms and exclusion terms. Again, the inclusion terms may be phrases that are synonymous with that condition, like a CVA. Sometimes it's called a stroke. So if you're looking up CVA, they'll say includes stroke, includes this, so other terms that you would use for that same condition. Here are some excluded notes, okay? Excludes notes are looking at a couple different things. Some of them are telling you that 2 conditions cannot be reported together, okay? So we give you an example of chronic bronchitis and COPD. If you've got COPD, you've long passed chronic bronchitis a long time ago, okay? So if you can't have both conditions. If you've been diagnosed with COPD, you're not going back to chronic bronchitis, okay, because you've already advanced into pulmonary disease now. Same thing for the R53.1 weakness and the M62.81 muscle weakness. You're not going to use R53.1 for weakness because you already described a more specific code that was what type of weakness? Oh, yeah, muscle weakness, okay? So you're not reporting both of those conditions at the same time. Now, the excludes 2 note has conditions that are excluded are not part of the condition represented, but your patient can have both at the same time, okay? So we're looking at someone that has acute bronchitis and chronic bronchitis. You can see that they have 2 different codes, J20.9 and J42. Your patient can have both of these conditions at the same time. Sometimes it's called acute on chronic bronchitis, okay? When this happens, okay, it's going to tell you if you have to use an additional code to describe the type of bronchitis or the type of bacteria, if they've got a bacterial. Sometimes it's going to tell you to code first under the excludes note. And we're always coding the acute condition before we code the chronic condition, okay? And again, if we're talking more about coding in the medical record than on the claim, because if they have acute bronchitis, you may not be coding the chronic bronchitis on the claim. You may just be including the acute bronchitis since that's the skilled condition that you're reporting. It wouldn't be a bad thing to include the acute and the chronic, but the acute is more of what you're skilling the patient for. Again, some signs and symptom codes or other diagnosis codes may be excluded as well, and the instructions will help to guide you with that. Okay, so the example that we give are excludes 1 and 2 notes. So G25 coding family is we're going to look at tremors, okay? So we're looking at essential tremor, which would include the familial tremor, meaning that you have a family history of this, and it excludes the tremor NOS, not otherwise specified. Why? Because we included more specification in the actual code, saying that it was a familial tremor. It was related to a familial, something in your family, okay? So you would exclude not otherwise specified because we did already specify it. So it kind of makes sense. Dystonia at G24 includes dyskinesia, but it excludes ethnoid cerebral palsy. Why? Because it has its own diagnosis. So if you have dystonia that's related to someone that has the adenoid cerebral palsy, there's going to be a code under the G80 family code that will address that under cerebral palsy. This is looking at that symptom of dystonia without the inclusion of the cerebral palsy. So it excludes someone that has cerebral palsy. You're going to go to the G80 category to look up someone that has dystonia with that condition. Okay, so it kind of makes sense when you think about it for a while. All right, coding conventions, use code first or use additional codes, mean sometimes conditions or diagnoses have an underlying etiology, meaning how did I get that condition or why did I get it, okay? And then sometimes multiple body systems are affected or this disease manifests itself in multiple body systems, okay? You can have multiple body system failure. And again, you would need to use additional codes to describe the extent of the damage from this original condition. So etiology codes, they use additional code that tell you what the condition came from. And again, a lot of times this happens with our diabetes codes. And manifestation codes tell us to code something else first. So if you got a condition with your vision related to diabetes, it's going to tell you to code the diabetes first because the diabetes caused the visual condition that you have. So you're going to have the diabetes as the first code and then your visual condition as the second code. Okay, the manual will instruct you in that way. So manifestation code titles will include in diseases classified elsewhere, which again is sending you someplace in the manual to go and look up this disease because we've classified it in another chapter. So go to this chapter. It sort of like helps to guide you all around the book. So additional coding guidelines for 2017, your etiologies or manifestations, again, it's going to tell you to code something else first, use the additional code or in diseases classified elsewhere, okay? Sometimes you have both an underlying etiology and multiple body systems, in which case you're going to be coding all of that. What I'm talking about is medical record coding, not necessarily claims coding, because I remember there's 3 different ways and places that you code different things. If there's a combination code, again, you're going to use the combination code. And some instructional notes may tell you proper sequencing based on etiology, manifestation, and then the final code. All right, so here's an example of someone that has glaucoma. So H42 is the family code for glaucoma. It's going to say glaucoma in diseases classified elsewhere. So it's going to tell you to go to that condition that caused the glaucoma. Was it amyloidosis? Was it aniridia? Was it Lowe syndrome? Again, Rieger's anomaly. Was it another metabolic disorder? So it's going to tell you what other coding family to go to code that first and then the diabetes second so that we know that the glaucoma second so that we know that one of these conditions caused that person's glaucoma. So based on how we sequence it in the medical record, we can tell what caused what other diseases. With, again, means associated with or due to. It means you have, like, diabetes with retinopathy, okay? It tells you that those two things went together. It presumes a causal relationship between those two conditions, and they should be coded as related, sometimes even in the absence of documentation for certain conditions, because they assume that those two things go together. And as we get into other chapters, that's going to be relevant when we're talking about end-stage renal disease, some cardiac conditions, hypertension, and those types of things. Your C or C also is going to direct you to another place in the manual, again, because you're going to see a lot of the C or C also in the alphabetic list. And so it's going to have you look up one condition, then it's going to say, go over here to this place because your more specific information is likely held in this part of the manual. So again, it helps to direct you as to where you need to go to look for more information. Code also, when 2 codes may be required to describe a condition to its fullest extent, it's going to tell you code this and also code this. So for instance, when we have folks that are diabetics, it also wants us to code how are we managing the diabetes. Are they using long-term insulin use? Are they using an oral anti-diabetic agent? Are they using an oral hypoglycemic agent? Okay, so it will tell you to code also. Same thing with end-stage renal disease. It wants you to code for the stage of the renal disease, and then if they're on dialysis, we're adding an additional code. So it'll say code also. And it doesn't direct the sequencing of the code on the claim. We're talking about how the conditions are sequenced in the medical record. Default codes, again, you never want to code from the 3-digit list or the 3-character list. You always want to take it back to the tabular so that the condition is reported but not identified as acute or chronic and no information is available. Again, sometimes your default codes or your only 3-digit codes are all you've got to work with for some of these diagnosis codes, but you always want to verify that in the tabular list. Always, always, always go back to that tabular list. Some general coding guidelines. Finding the code, again, you first look in the alphabetic list. You verify it in the tabular list. You use the instructional notes that tell you how to code to the most appropriate level that you've got, whether you need a 4th, 5th, 6th, or 7th character, including your laterality for those extensions where you need that. You're going to need that information. And then you're going to verify all that in the tabular list to make sure that your final code is the one that you need. Looking at level of detail, the diagnosis codes that are supposed to be reported should be at the highest number of characters that are available for that code, and we have to get that information that's the most relevant. So the 3-character code should only be used if it's not further subdivided to a 4th, 5th, 6th, or 7th character in the manual. Okay? If we have more, if we're supposed to have 4, 5, 6, or 7 codes there, and we report a code that only has 3, it's considered an invalid code. Okay, that may be what your biller comes back and tells you when she does the billing. Signs and symptoms. We should not be coding signs and symptoms if the diagnosis is a reason for those signs and symptoms. So, for instance, if someone has a fractured bone in their body, what we say is that there ain't no pain like bone pain, right? So we assume that if they have a fractured, let's say, femur, because that's the biggest bone that you've got in your body. So if I have a fractured upper leg, of course I'm going to have pain because I have a broken bone. So you're not going to code the fracture and the pain. It's assumed that you have pain because you have a fractured bone. Same thing with your folks with pneumonia or COPD. We know that they're going to have a cough. That's one of the symptoms of that disease, so you don't need to code pneumonia and then code a cough as separate. We know that they have a cough, okay? If the symptoms are integral to the diagnosis, they're reported with the diagnosis. If they have signs and symptoms that are routinely not assigned with that diagnosis, then you need to have a second code. So if you have, a hangnail, and now you've got pain in your right leg, those two things are not related, okay? So that's what we're really talking about here with some of those signs and symptoms. So if there are additional signs and symptoms that are not routinely associated with that disease process, then you're going to add a second code to report that second condition if it's not an integral part of the disease process, okay? So again, when you have multiple coding for a single condition, it's going to tell you to use additional codes from the tabular list. For instance, if someone has an infection, and if it's a bacterial infection, it's going to want to know what type of bacteria caused that infection. So it's going to tell you to go to include additional codes. Sometimes you have manifestation codes that's going to say code this condition first that caused that condition, or sometimes, again, that causal condition has to go first in how it's listed in the medical record. So use the coding guidelines in the manual to help you with that. We talked about acute on chronic, and if they have an acute and chronic condition, it's, of the same condition, and they have acute and chronic, the acute needs to be sequenced first. Combination codes. Sometimes there are single codes that's going to classify 2 different diagnoses, and again, they've used combination codes in the ICD-10 process to help us, to help guide us, and to make it a little bit easier for us. So you're not going to use multiple codes if there is a combination code that can describe the same condition. Again, do yourself a favor. It's one less code you got to look up. Like we had mentioned before, sequela are residual effects after the acute phase of an illness or injury has terminated, okay? So if they come in for a fractured hip, rehab's done everything that they can, they cut the patient off of rehab, or consider that illness or injury has been treated and now it's no longer active. If something happens with that condition down the road where they're starting to get pain or other symptoms, an unsteady gait, something like that, that might be the sequela, okay? There's no time limit when you're using a sequela. The condition or the nature of the sequela would be sequenced first, and then the sequela code is sequenced second, okay? So keep that in mind, especially when it comes to Part B claims. An acute phase of an injury or an illness is never going to be coded at the same time as a sequela because, again, you can't be inactive and have an after effect at the same time. Again, threatened conditions or, those types of things are not reported in skilled nursing facility. Complications of surgery and other medical care, they did add some post-procedural conditions as well, like especially hematomas and seromas, those types of things they added with many medical conditions into the manual now. So again, they're getting more specific, all right? Again, documentation will help to guide us with code assignment, and if there is a cause and effect, that has to be documented in some conditions that don't have combination codes. Syndromes, again, the same thing. We don't usually report syndromes in long-term care, but how is that being represented in the patient? How is that syndrome? What symptoms are they having? That might be something that you want to include in the medical record because it may affect your care planning decisions. Documentation to support BMI and pressure and non-pressure ulcers, we can get without using the physician. So if we're looking at basal metabolic index or body mass index, we can get that information from the dietitian. And when you're looking at staging pressure ulcers or looking at non-pressure ulcers, we can take that documentation from one of the nurses, the RNs that's doing that assessment. So you don't need to have that specifically from a physician, but those are the two places where we wouldn't need a physician or a physician extender. Again, if there's conflicting documentation, and those of you that are on the line that are MDS coordinators know exactly what I mean by this. Patient gets admitted on Friday. The admitted nurse is calling the skin eruption A. The wound care nurse comes in on Monday morning. She looks at it. She calls it B. We don't know what it really is, so we get the wound doc in thinking he's going to have the best description, which, believe me, don't assume because they're doctors they know more. And then he calls it C. So now the MDS coordinator is sitting there on the 7th day looking at, I have the same skin interruption and it's called 3 different things, and what do I call it in the MDS? So you all know what I'm describing here. So again, query the physician to clarify any conflicting documentation. All right, when it comes to selection of the principal or primary diagnosis codes, it's going to depend on whatever's in the manual that tells you have to code something first versus second. And again, I'm talking in the medical record, not necessarily the claim. All right, so the classification itself that provides the sequencing instructions will tell you if you need to code something second. All right, if there's no specific instructions, then you're coding based on the condition that brought the patient to your healthcare setting, not the hospital. Let's not go down this rabbit hole like we did in ICD-10, where someone taught you how to do this who is a certified professional coder and said, well, we have to code this way and we have to do this. That's how you got into trouble in the old system. So let's make sure that you understand that this is the condition that brought them to your healthcare setting, the skilled nursing facility, not what brought them to the hospital. Okay. When 2 diagnoses are listed as first or primary, if there's no coding instructions that tell you that you have to use one before the other, like what caused the glaucoma, that example, then either of the conditions can be used. Again, you're going to look at what's the reason why you're mainly, admitting the patient, okay? Unless the circumstances of the admission or therapy or whatever you're giving that patient can help you decide which one is the principal diagnosis, then either condition can be listed as the first. Secondary diagnosis, again, it doesn't matter from the second forward how they're sequenced, but again, make sure when you're looking at claims, all the diagnosis codes that you have there tell me the story about why this person's skilled. If there's something that affects the skilled service, slows them down, makes them not able to participate, would require a longer length of stay, put that on the claim. Okay, so other diagnoses would be any secondary diagnosis that requires clinical evaluation, therapeutic treatment, diagnostic procedures, a longer length of stay, or nursing needs to monitor those folks for some condition. Previous conditions, again, if it's resolved, we don't need it in long-term care, but sometimes you might want to know that information for care planning purposes. So I would want to know if my patient has a history of falls because that will influence my care planning decision, you know. So sometimes we're interested in some of those, but again, they're not required to be reported. Infectious agents that are causing diseases, again, the infection might be coded in another chapter, but it might send you into any other instructional notations that are going to help with the final code assignment, like if it's a certain bacteria. Or if it's an antibiotic-resistant infection, it might send you all the way out to Chapter Z to look for those codes that have resistance, right? Bacteremia, sepsis, severe sepsis, and septic shock are 4 different things. A lot of times those terms are used interchangeable. Keep in mind they are not interchangeable terms. They mean something different. Bacteremia is looking at bacteria that's in your bloodstream. Sepsis is looking for a serious body-wide response to bacteremia or another infection. Severe sepsis is when you're starting to get some kind of failure in the body, okay, and you have inadequate blood flow. And then septic shock is, is a life-threatening condition, okay? So make sure that you have the appropriate diagnoses when you're using these different conditions, all right? Bacteremia and septicemia are not coded as sepsis. They have completely different codes, and urosepsis does not mean the same thing as sepsis. And sepsis is a condition that they use a lot in the hospital because it has a higher reimbursement rate. Neoplasm code assignment, again, we talked about neoplasms. You need to know whether it's malignant, whether it's benign, whether it's in situ, or whether it's uncertain to be able to assign that final code. The alphabetic index should be used to locate the appropriate term for the neoplasm. Then you're going into the neoplasm to give me more specific information about malignancy or benign. Tell me where it is. Tell me if it's right or left. And some will denote whether it's male or female. Okay? So again, the tabular list needs to be used to have that accurate assignment of that final code. All right. Our diabetes codes give us a lot of these combinations so that we would need to know the type of diabetes a person has, the body system or systems that are affected by the diabetes, and any complications that this person might be suffering related to the diabetes, okay? So you can use multiple combination codes within the diabetic category, and then it might also say use additional codes to identify how you're managing the diabetes. Okay, and then your Z79.4, as you can see below, with long-term insulin use. So under Chapter 4, the new excludes notes would exclude diabetes with hypoglycemia from E16 through E16.2, okay, because it has other sections where it's going to address diabetes with hypoglycemia. It's going to send you to E08, 10, 11, or 13, okay. Use additional codes. You're going to find those at E08, 9, 11, and 13, which are telling you how are you managing this person's diabetes. Is it by insulin, Z79.4, oral antidiabetic, or oral hypoglycemic? So it's telling you if you're coding anything at 8, 9, 11, or 13, tell me how you're managing that. All right, so if the diabetes is not documented, your default category is going to be type 2 diabetes, which is E11. If it's secondary, meaning that it was caused by another condition or event, you're looking at E08, 9, or 13. Again, look for additional coding instructions or use additional codes or code first, depending on the other comorbidities, manifestations, or etiologies that are involved. Again, we're not talking about gestational diabetes or anything with pregnancies for this. This is your little cheat sheet looking at the types of diabetes. All right, so you have folks that have diabetes due to an underlying condition, so something caused the diabetes. E09, it was drug or chemical-induced diabetes. Type 1, type 2, or another type of diabetes. Again, your specifics about what you're using to manage that. Keep in mind if it's temporary use, like an emergency situation for insulin, that's not long-term use. You're not coding that here. And if they did have a pump malfunction, you're going into Chapter Z to look up pump malfunction as one of the conditions. All right, your I chapter, hypertension with heart disease, has another boatload of combination codes. It has heart conditions for I-50 and I-51. Those are combined into codes from the I-11 hypertensive heart disease when there is a stated or due to relationship, okay? So if your hypertensive heart caused your heart condition, there's going to be a code that's going to be wrapped up to describe both conditions in one code. If the patient also has heart failure, so not just heart disease, but heart failure, you're going to need to code something from the I-50 category to identify the type of heart failure that they have. If there is no causal relationship stated, then no combination code can be assigned, okay? So if the provider identifies that it's a different cause, then you will be reporting two separate codes. So again, you might want to query the physician to get down to utilizing one code when it's appropriate. Your I-12 is your hypertensive chronic kidney disease. So again, there's combination codes from I-12 that are used with your N18 CKD diagnoses, okay? Now, when it comes to hypertensive CKD, it's assumed that there is a relationship unless the provider says that there is absolutely not. You're going to assume that these two things are related, that the hypertension caused the chronic kidney disease, okay, unless that provider says no. So CKD with hypertension is now called hypertensive CKD. And again, the revisions from this past year tell us that CKD shouldn't be coded as hypertensive if the provider indicates that it's not related, okay? Without the note telling us it's not related, we will assume that they are related. And it's also telling us to make sure we identify what stage of chronic kidney disease this person has as a result. So hypertensive heart and CKD, I-13 must have a stated hypertensive heart, assume a relationship between the hypertension and the CKD, again, unless it's not stated, use your N18 stage of chronic kidney disease, and your I-16 will not be used in long-term care because that's a hypertensive crisis or emergency situation, and that's usually done in the hospital. We usually don't manage that in long-term care. So if your residents have both acute and chronic kidney disease, you're going to need the additional code to represent that acute condition, when we're coding that in the medical records. Your CVAs, okay, your sequela I-69. Conditions are classifiable as the categories from I-60 through I-67 that indicate cerebral vascular disease as the cause of the late effect. So when you're describing the neurological deficits related to the CVA, you're probably looking at I-60 through I-67, okay? If those deficits of the CVA, again, those would be what you're reporting. And if no neurological deficits are present at all, no, drooling, no facial droop, no, dragging leg, no, any of that stuff, okay, then you're going to use a history of the CVA. If they have some residual effect, then that's what you're using to describe I-60 through I-67. All right, circulatory system, again, I gave you a little cheat sheet here that there was an expansion of the sixth character to involve cognitive deficits that related to a cerebral hemorrhage or an infarct. So if they have spatial, visuospatial, or attention deficit, or cognitive, social, or emotional deficit, or something else, these are the numbers that you're going to use, so I gave you a cheat sheet for this. Again, patients admitted with pressure ulcers, again, the pressure ulcer should be described as healing and assigned for the appropriate pressure ulcer. And again, we know in the MDS world, at the highest stage that it ever was, you're never backdating a pressure ulcer on the MDS. So if you have documentation in the medical record that maybe it's presenting as a stage 3 right now, but it's a healing stage 4, you should be coding that as a healing stage 4. Because if that flips to a 4 from a 3 now you look like you have a worsening pressure ulcer when it really was a healing stage 4 to begin with. Okay. If you're unaware or you don't have enough documentation for that pressure ulcer, again, look at your providers, okay, to get that clarification that you're going to need. All right. Look at whether they were present on admission, whether they were discharged, and find the right stage, and query the folks that you need to. Again, admitted with a pressure ulcer that's evolving into another stage during admission, what they're saying here is that if they started off, they were a healing stage 2 when they came into the facility. Now we grew it worse to a stage 3. They're saying that they want the stage 2 and the stage 3 in the medical record. And if it came in as a stage 2 and it turned to a stage 3, okay, I might report both of those on the claim because I started off treating a stage 2. Now I'm treating a stage 3. And if that's all in the same billing period, I would include both. Let's say I had a 5-day that was done in March because the patient came in on March 21st, okay? And then in April, that moved from a stage 2 to a stage 3. On my April claim, now I'm putting a stage 3 pressure ulcer rather than the stage 2 that I had. It is okay to update diagnosis codes so the person still stay. You don't necessarily have to keep all the same codes that you did on admission. And in PDPM, we're going to see even more of that because you're choosing a code right on admission for that patient, but there may be a second condition. So let's say they're coming in for a fractured hip, and that's what you choose at first. And then the fractured hip is healed, and now you're treating a residual pneumonia. So the pneumonia is going to be the primary reason why you're storing that patient. That should be in the primary position on the claim. Okay. Traumatic fractures, we had talked about this, displaced versus non-displaced. We're just talking about it again because we're going into the chapter on traumatic fractures, but nothing's changed. You know, again, you only use the 7th character. You don't use the Z codes, even if they did replace. A D is what you're usually using in long-term care. The A is usually that initial encounter. You could be using the sequela, okay? Pathological fractures and osteoporosis. The 7th character is to be used to identify whether it's initial or subsequent encounters. Again, even if we're not sending the person to the emergency room, when we call that doctor to say, here's what she's presenting at, it looks like a fracture to me, and they evaluate the patient, that's the initial treatment. When they tell us, I want you to, put a sandbag next to her leg, make sure that you turn her turn and position her this way or that way, that's our subsequent, okay? Keep in mind, M81 is your osteoporosis with no current pathological fractures. The M80 are your folks that have osteoporosis, and they do have current pathological fractures. If they have a personal history and they have healed osteoporotic fractures, then you're looking at the Z codes for that aftercare component. This is your cheat sheet for 7th characters when it comes to fractures. Initial encounter of open or closed, subsequent encounter for routine or delayed healing, subsequent encounter for non-union or malunion, or the sequela. The A and B are the ones that we are not likely to use, at least at this point in time. D through S are those we are likely to use. 7th character, again, is A, is received for that initial active treatment of the character, even if they go to multiple providers, as long as they're still undergoing that initial treatment. So sometimes you'll get a patient who goes to one hospital and they have to be airlifted to another hospital, okay? Or they go from one physician to a specialist. That's still considered the initial encounter, even if there's a delay in healing, okay? So you may not get to that specialist for a couple of days, but that's still considered that initial encounter. Then they will give us the direction on how they want us to treat that moving forward. So we are generally the subsequent healing or recovery phase for any type of those injuries, okay? Again, Chapter 20, we're external cause codes we do not use. Here are some of your cheat sheet Z codes. Again, we just wanted to give you some opportunities that you can just cut something out really easy, put it up on your computer, tape it up there. Your orthopedic aftercare Z47, again, if you have orthopedic aftercare, for the love of God, please tell me what joint was replaced. Encounter for other post-procedural aftercare, Z48, please tell me what that other post-procedure was, okay? So if you're using that Z47 code, again, use the additional code to identify what joint it was, because it's not specific enough. There are additional Z codes that can also help you with other presence of other conditions, okay? And again, just wanted to give you a cheat sheet, so if you're looking at certain areas, you would have the opportunity to be able to do that. Give you an example of some ICD-10 coding under PDPM. Those codes that are in blue on this slide are codes that we should have considered. So when we're looking at this patient, we looked at the diagnosis codes that were on the claim. The person was really there for a fractured femur, and we didn't even get that until you get, like 7 codes down or something, okay? So we're just looking at sequencing of codes here and how that process would look. So I want to hand it back now to Lori. I know we're right at the bottom of the hour or the presentation, but I am happy to stay on and answer any questions that folks may have.
Thanks, Maureen. That is a lot of information to take in. But you did a great job, and we appreciate it. I think because we're only allowed, so many minutes, we'll have to end our presentation today. But we will gather all the questions. I will get them to Maureen, and then we'll send them out to everybody on the email that you used when you signed in. And so we thought we would have time, but it's a lot of information to take in. So we appreciate everybody joining in, your time and participation. Please take a final moment to complete the webinar evaluation. It will come up as you exit, so just give it a little bit of time, and then you can get your attendance certificate as well. And so thank you, and enjoy your day. Speakers, will you stay on the line?
Yes, ma'am.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect. Speakers, please stand by for post-conference.